everyone. Welcome to this lunch symposium. Bon appétit, everybody. My name is Professor Thomas Rimmelé. I am anesthetist and intensivist working in Lyon. And I'm very happy to chair this session with Dr. Ricard Ferrer from Barcelona. We will have 90 minutes together, and we will have 4 interesting talks. I will ask the 4 speakers to respect the time allocated. So it's 18 to 20 minutes per each speaker, so we can save time at the end for 10 to 15 minutes of discussion. I hope there will be a lot of questions on this very important topic. So without any further notice, I will ask the first speaker, Professor Massimo Girardis from Modena, to get on stage for his talk on endotoxemia and endotoxic shock, rationale and pathophysiology.
Hi, Mr. Chairman. Good morning. Good morning to everyone. Great pleasure to be here. I'd like to thank the Estor for the great opportunity to be here and to share with you some, at the beginning, some rationale and pathophysiology of, I think, one of the most important part of our life in infection and sepsis, that is endotoxemia, and a sort of basic approach to the problem of endotoxic shock. Here you have my disclosure, not particularly disclosure for this lecture. I just want to start with our enemies, and the first enemy that I want to present you is now a famous enemy. The first one enemy in the last 2 years, that is the COVID-19, the virus, coronavirus. Of course, you know, many kilometers of literature are now available for COVID-19 disease. But, you know, at the end of the story for me, and I think for many of you, the COVID-19 is a sort of sepsis for our patient. Different sepsis, maybe from a bacterial sepsis, but not different from other virus infection. But I just want to skip, because I know that Ricard, after my presentation, will have a focus on the potential effects of endotoxemia and treatment of endotoxemia in COVID-19 patients. But just want to remind that now, today, and in the past, and in the future, we will have to face with our other enemies, and the most important thing are bacterial. And here you have one of the most important bacteria in our daily life with our patient, that is E. coli. You know, E. coli is more than 30% of infection in the ICU's patient. And what is important, that when we seek to the E. coli structure, we can understand that one of the important molecules in the E. coli is the LPS. LPS is more than, there you have the number there, 4 million of molecules for each cells of E. coli. And you know, LPS, endotoxic molecule, are responsible for many effects. But what is impressive for me was some years ago, when I just had the opportunity to study this problem, is that during infection, when I give an antibiotic to our patient, you can see what happens at the membrane of the E. coli. You have an explosion. This is the effect of beta-lactams on E. coli. You have an infection in the blood, give the antibiotic, and what happens to the microorganism? With the beta-lactams, with the blocking of effusion pumps, you have an explosion of the bacteria. What does it mean? It means that you have a lot of endotoxic substances, transmission, and in particular LPS, that could have a detrimental effect in our patient. This is impressive. I think this image is more important than everything that I will give you in the next minutes, because you have to remind that when you treat a patient for infection, this is the effect of antibiotics. And it means that antibiotics are quite important, but maybe that in some patients we have to do other things that only management with antibiotics. Just really very simple concept of immune response to infection and to microorganisms. particularly in this case, we have bacteria. You know, we have endotoxin. Endotoxin is a pathogen-associated molecular pattern that stimulates our immune response, innate immunity at the beginning. Then we have the adaptive immunity. All the immune cells that you know are involved in our response. And at the end, we have, could be different patterns of response. We could have just a very balanced response with a great normal situation, some fever, no organ dysfunction. You wait for your antibiotic, you are a very good immune system, and you could have just a normal infection. But, you know, that sepsis is dysregulation of the immune response, and when we have the same story, but at the end the immune system is not answering to our aggression, to the aggression from the bacteria in a very regular way, but is in this regulated way, we have the sepsis. And here you have the cascade from endotoxemia, from a bacteria, lysis of E. coli, or from other gram-negative bacteria, but could be also in gram-positive bacteria. And you have the effects of the immune cells on the right, and then on the left, you have the final effects at the organ level. We have to, of course, as I said before, treat the patient for stopping the replication of the bacteria in the lung, in the blood, and in the urinary tract. But when this cascade is activated, your chance to be in sepsis or septic shock depends on your immunity system, even if you receive the right antibiotic at the right time. And this is the reason why many patients after emergency department admission and the right antibiotic in the right time, during the time the hospital or in your ICU could worsening. And that's a point, it's an important point, because I think that when we have this kind of patient, we have to manage this patient, we have to remind that, yeah, fluid resuscitation is okay, yes, okay, antibiotic, blood culture, for sure, and of course, vasopressors if it's needed, but we have to think out of the box, so very easy and simple 1 hour bundle. And this is, for example, what happened at the endothelium level. Endothelium, you know, is one of, it's the biggest organ that we have in our body, more than 100 and something, 1,000 and something square meters of endothelium we have in our body. And you know that one of the more quick events that we have during a sepsis is the involvement of endothelium. You have all the transmission mediators in this slide, but at the end you have a coagulation involvement, disruption of tight junction in endothelium, and so the effect that you have in your patient very quickly, for example, in patient with meningococcal invasive disease or pneumococcal invasive disease, you have a stop in the microcirculation as well as edema formation because of disruption of tight junction. Alterated immune response, hypercytokainemia in our patient means microthromb in the microcirculation and edema for changing of filtration rate in our patient. What about the second part of the story after 1 day? You know, as I say, the story is between microorganisms, antibiotic, your treatment, and your immune response. And we know from many years that we have to change our approach. Some years ago, more than 20, we believe that we have a pro-inflammatory at the beginning, then anti-inflammatory response. Then we got that probably it depends on the patient, but now we have to put in our view of the patient and consider in each patient that at the same time, in the same moment, we could have 2 different patterns or 2 different expression of the immune system in our patient. One is all the line connected with the hyperinflammation, and the second is the red line in this picture. We have, we have there, not red. Here you have this third picture, you can see that we could have some pro-inflammatory and anti-inflammatory innate response and adaptive response to infection. At the same time, it depends on the balance between 2. If we, at the end, in some days, the patient, we move to a persistent pro-inflammatory state or in an immune failure phase, could be, as for example, in COVID-19 patient, that we have at the same time a pro-inflammatory persistent state combined with the immune failure or immune depression phase. The reason for this immune failure during sepsis course is now clear. The majority, the most of the cells involved in the immune system are involved in this kind of immune failure. Here you have a picture summarizing all the effects that we have during the persistent course, persistent inflammation on the macrophage, the dendritic cells, concerning, of course, the T cell, the B cell, immunoglobulin production. This is not important now because this could cost more than 1 hour for discussing about that. I want to come back on the endotoxemia, and I want to come back to endotoxin role in this story. The first important publication on the role of LPS and endotoxin was published in 2004 by the group of John Marshall, and they measure at ICU admission the endotoxic level in patient, and they observe that we have a lot of patients here on the left part. We have a lot of patients compared with normal subject with very high level of endotoxemia. And at the same time, there is a close relationship with the level of endotoxemia at ICU admission. These are not only septic patients. These were also patients with other reasons for ICU admission. There is a close relationship between endotoxin levels and the outcome of the patient as expected. You mean, again, endotoxemia at the beginning, at the ICU admission, and mortality of the patient. We did some, our aim some years later was to understand if we could use endotoxic level for predicting the organ dysfunction development in our patient with infection and also ICU admission. We decided to measure endotoxin level not in the ICU but before the ICU, and we measured, you know, at the time 0, after 6 hours, 24 and 48 hours, and just this was an observational study, and as you can see in the slide, you see that the patient with a very high endotoxin level since the beginning of infection develop organ dysfunction. Now the name is sepsis. At that time was severe sepsis, and they need ICU admission. So again, endotoxemia could be important only after ICU admission, but may play an important pivotal role also before ICU admission. And I think this is the next for the future to expand this concept of measurement of endotoxemia also in patients before ICU admission. Here I just want another impressive image for me was when I look at this, what's great, because I'm in sepsis, the role of microcirculation is crucial. Many experts indicate that microcirculation is the key for changing the outcome of your patient. If you have some problem at the microcirculation level, probably the patient at the end had a bad outcome compared with patients without microcirculation impairment. And this is an animal experiment included in some rats, and they infuse some E. coli in the blood, and they measure with microscope the endothelial response and the microcirculation. And you can see that after 3 hours, we have a block of the microcirculation and perfusion at the capillary level. And again, the major role for this thrombosis probably are the endotoxemia, are the LPS generated by the microorganism. What about the third phase of sepsis? Infection, hyperinflammation combined with immune tolerance. At the end, probably in many patients, we could have a sort of immune paralysis. Again, endotoxin, and you can follow the pathway of endotoxin, but could be other PAMs generate after hyperinflammation, as I said before, a pathway for maybe immune failure in our patient. And when you have a patient with immune failure, probably it's a patient not with shock or just with a sort of persisting shock, but it's a patient prone to secondary infection. And many of the patients that we have in our ICU, again, COVID-19 patient is a typical population with this problem. We have secondary infection and opportunistic infection. That is the signal for immune failure. what about the removal of endotoxin? I know that Sylvia, maybe Ricard, will spend more on that, but looking to the effects not on outcome as mortality or time on vasopressor or ventilation-free days, but looking to some markers, biomarkers related to the physiology, the pathobiology of sepsis. You can see that here you have, this is an experience coming from Milan. You have in the y-axis interleukin 10, interleukin 6, and TNF, the three most important cytokines, pro-inflammatory cytokines, and you have the effect of blood purification for eliminating endotoxins, and you can see that if I could have a good elimination, a good control of pro-inflammatory cytokine, the probability of survival of the patient increases. Other important points is at the microcirculation, as I show you in the animals, but you can see also in your patient. If you have a microcirculation impairment, you are in some trouble, and this is another interesting experience by measuring in vivo with the microscope, electronic microscope. It's on live, I don't remember exactly the methods. You can see that the use of hemoperfusion for clearance of endotoxin can change the situation of the microcirculatory level, increasing the perfusion and particularly the small capillary perfusion. Again, other important effect in terms of pathophysiology is the effects of early removal of endotoxin in terms of immune failure. This is an elegant experience published where the authors measure in patient treated and not treated with Polymyxin the response of the immune system, and you can appreciate that patients that receive purification from endotoxin at the end of the story, low risk for going in a sort of immune failure by low HLA-IDR, by an increasing of HLA-IDR expression on the monocyte. I think that I'm going to the conclusion. My message is that for sure antibiotic, for sure the sepsis is remain important in sepsis, to have a time-appropriate management. And the three cornerstones of treatments, blood culture, antibiotics, and resuscitation remain important. But we have to think that probably if we have not able to control immediately the infection, and if you have a patient with many dysfunction, multiple organ dysfunction, could be that antibiotic and resuscitation alone is not enough. Are not enough, and so we have to move to a more pathophysiology approach to adjunctive therapy as, for example, blood purification. And my recommendation is that when you have a patient, don't be lazy, measure something concerning hyperinflammation, the red part, and also, of course, the adaptive immune suppression. Thanks so much.
Thank you very much, Massimo. So we're going to ask you to keep your question for the end of the session. And now we're going to ask my co-chair, Ricard Ferrer from Barcelona, to talk about the superimposed infections and endotoxemia in particularly COVID-19. Ricard.
Thank you, Mr. Chairman, for the nice introduction. Thank you to Estor for the invitation to be here. And thank you to all of you for being here, and those who are following the session virtually also, thank you for attending. So I'm going to talk about superimposed infections and endotoxemia in critically ill COVID patients, and also about the gut-lung axis. Those are my conflicts of interest. I'm going to start with a clinical picture. It's a 51-year-old woman with obesity that was admitted in another hospital because fever, dyspnea in April 20. She presented with high fever, tachypnea, low saturation, SARS-CoV-2 positive in the nasopharyngeal swab. And the patient, as you can see in the X-ray, has a bilateral infiltrate. The patient was supported initially with a half-flow nasal cannula, was treated with the antivirals that were available in 2020, and also with some antibiotics and some immunomodulators, as still we are doing. The patient was admitted in the ICU of this secondary hospital. The progression of the illness, the patient needed intubation, mechanical ventilation, deep sedation, neuromuscular blockade, and prone position. So on third day, our center was activated for ECMO retrieval in that center. So this is the CT scan at the arrival of my hospital. You can see the severe bilateral alveolar consolidation in this scan. So the patient was supported with ultraprotective mechanical ventilation, supported in ECMO, of course. And on day 20, the patient had an increase in tracheobronchial secretions, purulent tracheobronchial secretion, leukocytosis, increase in biomarkers of inflammation, C-reactive protein, also procalcitonin. And of course, these type of patients are difficult because there is no change in the chest X-ray, no change in the oxygenation, no change in the body temperature. Of course, the patient is with extracorporeal support. But there is some other signs interesting, which is the increase in vasopressor supports up to 0.5 mics per kilo per minute of norepinephrine, and also an increase in lactate. Also, we observe some fibrin deposits in the oxygenator and prolonged coagulation time. Endotoxin activity at this point was 0.8. So the question here is, which is the diagnosis? And of course, many of you, it's not an easy case because, as I said, with extracorporeal support, it's difficult to make this approach. But of course, here the diagnosis is a ventilator-associated pneumonia. And the question also that we can discuss at the end, if this patient merit for PMX hemoperfusion at this stage. So the diagnosis was confirmed. The patient was treated empirically with meropenem and plasmamycin. The microbiological diagnosis was an MDR Pseudomonas aeruginosa, identified in the bronchoalveolar fluid and also in the blood cultures, and the patient received direct therapy with ceftolozane tazobactam. So the patient, whatever the treatment, responded quite well, and on day 22nd received the tracheostomy. There is a CMV reactivation showing the depress in the immune system due to these both infections, but she also recovered for that. We have some technical problems with the ECMO that is not necessary to discuss now, but the patient did well. But she received 67 days of ECMO support and 92 days of ICU stay. And the patient did well, as I said. So probably you have recognized this picture because you have seen this picture many times. So you know that SARS-CoV-2 is able to reproduce very fast in the bronchial epithelial cells. You can see millions of virions after the infection, and the clinical picture can go for something very mild, for something very severe, and the difference between patients that have a mild disease and a severe disease is related to the immune system. So it's the immunity which is making the difference, and probably the typical pictures, and keep finger crossed, the typical picture that we have seen at the beginning of the pandemics is not very similar to what we have now with the new variants and the protection of the vaccines, but let's see for the future. But the severe forms of this condition, it's, and I agree with Massimo in that, is very close to what we call sepsis. So as I said, the difference between a patient with a severe condition and a mild condition is in the immune system. Those patients that have the severe COVID-19 have both high viral load. The immune system is unable to control the viral load, but at the same time, the immune system is activated in this process of trying to control the infection. So we have hyperinflammation trying to control the infection. The immune system is not able, and it's increasing inflammation. At the same time, the virus is keeping with the reproduction and increasing the viral load. I'm going to show some of the studies we did with that, and you will see that. Here you have the different in interleukin-6 level within different conditions. And it's interesting to see that because the levels of IL-6 in COVID is not so not so high compared to other conditions. But also it's interesting to see that we consider tocilizumab as a therapy for COVID, or studies are showing some effects in COVID patients. But so we have tocilizumab for cytokine release syndrome, very, very high levels of interleukin-6. Tocilizumab for COVID patients, mild levels of interleukin-6. For the conditions in the middle, RDS, sepsis, we are not using tocilizumab. It's quite something that we also can keep for the discussion later. So with others, we described at the beginning of the pandemic the RDS related to COVID with inflammation in the alveoli, coagulation in the capillary, and the different phenotypes that you already know, and Gattinoni expressed very well in this publication, and also the involvement of other organs in this condition, and that's why we think it's like a sepsis, because there is many extrapulmonary manifestations linked to this infection. Especially, we will talk today about gastrointestinal involvement, but other are very important, like thrombosis, renal, cardiac, etc. So these are some of the investigators we did with our research group in Spain, showing that patients in the ICU have higher viremia, that patients not admitted in the ICU, and higher inflammation in terms of interleukins for those patients in the ICU, describing this critical illness in COVID. So we have severe inflammation, systemic inflammatory response, coagulation activation, tissue damage, endothelial dysfunction, activation also of the neutrophils, and some degree of immunosuppression. This is the typical COVID, severe COVID-19 patients we have, and also the effect of protecting, neutralizing antibodies that makes that people that need ICU admission, patients that need ICU admission, have better antibody protection. So this is already known, and also the role of the comorbidities that are present in many patients in the ICU, like obesity, hypertension, advanced age, is related to this pre-inflammatory condition, this pre-endothelial dysfunction that those patients have, that probably is a primer for the severe COVID. And also some genetic background, and this was described by a group in Italy and Spain. It was included in this paper, describing some genetic predisposition. So the clinical phenotypes for COVID include, at least in our, there are many other studies describing the phenotypes. This is the phenotypes we describe, and again in another research group in Spain by the Spanish Society of Intensive Care. The markers for mortality related to different organ dysfunction, but especially interesting in patients in the ICU. So severe patients, you can recognize different phenotypes from mild, moderate to severe, and inflammation, organ dysfunction, advanced age are between the factors that can differentiate different mortality for different subgroup of patients, and also the activation of the coagulation, that is quite important, because up to 25% of the patients have deep venous thrombosis or pulmonary embolism in many of the studies. So those patients probably are going to receive some type of immunomodulators, or at least the guidelines recommend for patients in the ICU and mechanical ventilation or ECMO that they have to receive dexamethasone plus tocilizumab. So this is going to affect what I'm going to talk about, which is the rate of superinfections. This is very well known for viral infections. More than a century ago has been described that those patients with influenza pneumonia, at the end, they die because secondary bacterial infections. The risk factor for that are age, comorbidities, prolonged invasive mechanical ventilation, organ dysfunction, and immunosuppression related to the condition, but also related to the drugs we are giving to patients. So this is the pathophysiology of the viral pneumonia that can be superinfected, mainly because of the virus have a direct effect on the mucosal and the epithelial, the alteration in the immune function that I have described before, and the enhanced adherence of the bacteria to these epithelial cells. Additionally, we are using immunomodulator. We have thrombosis that affects the macro and the microcirculation, and this is also facilitating bacterial pneumonia. Again, mucus production, lymphopenia can explain this condition. So this is the rate of superinfection in influenza pneumonia. Co-infection at the beginning is up to 16%. Superinfection during ICU stay in this study reproduced several years is variable, but it goes from 11 to 23%. For influenza, and mainly is by gram-positive cocci. Situation in COVID-19 is different. In this meta-analysis from the first early cases describe co-infection in 3.5% of the patients, so very low. Superinfection in 14.3% of the cases, so higher. But this European study, the COVAPIT study, that study patients in Europe with COVID-19 infection and compared to patients with influenza, pneumonia, and other patients in the ICU without viral infection, you can see that the risk of BAP is double respect to influenza pneumonia. So between these two viral infections, there is something different because patients with COVID-19 have double risk of bacterial superinfection during the ICU stay. This can be related to the condition itself, that can be also related to the condition we have in the ICUs during the different outbreaks, can be because of the relax of the prevention of VIP during the different waves of the pandemic, can be related to many things, but at least the data we have is that the risk is double than with influenza. And in this case, the most predominant microorganisms are gram-negative bacilli, especially Pseudomonas aeruginosa, as the case I presented to you at the beginning. Also some Italian data coming from Grasselli showing again that if the patient stays in the ICU for weeks, at least 70% of the patients are going to have a hospital-acquired infection. And again, especially for pneumonia, number one are going to be gram-negative bacilli, and also for UTI and for bloodstream infections and catheter-related bloodstream infections, gram-positive cocci are going to be number one. But gram-negative bacilli are involved in many, many of these infections. Of course, we also analyze this in my department. We include 250 patients in this analysis, and we compare patients with BAP in front of patients no BAP. And interestingly, corticosteroids are a risk factor for BAP. And for tocilizumab, despite you can see here a significant difference between patients with BAP, patients without BAP, when we control by propensity score, the difference for toci disappear. Epidemiology, very similar to the previous epidemiology that I presented to you, with a gram-negative bacilli as the main microorganisms involved in this condition, and Pseudomonas aeruginosa, of course. And pneumonia, this superimposed pneumonia is a risk factor for mortality, and those patients with pneumonia, as I said, receive more corticosteroids. So, as Massimo mentioned to you, this type of superinfections that produce an increase in LPS condition and can induce LPS or endotoxic shock with systemic inflammation, but also endotoxin is able to produce direct organ damage. So endotoxic shock can come from this gram-negative bacterial infection, but I want to spend some of the additional minutes that I have to talk about gastrointestinal translocation. This is quite interesting, and the great investigator, which is Didier Payen, in this review in Minerva anesthesiology, show the difference between a situation of homeostasis in the left and a patient that after any type of systemic inflammation has this altered gut barrier with different microbiome and difference in the immune system on the other side, and the facilitation for translocation of endotoxin from the gut to the blood, explaining the endotoxic shock that we can see in some patients without a formal gram-negative infection. Also important to recognize that some patients with COVID have gastrointestinal symptoms, so the gastrointestinal symptom is involved in those patients before ICU admission, before hospital admission, and also during hospital admission. And this group of investigators analyzed the kinetics of endotoxin activity in patients with COVID-19 pneumonia. And you can see that from day 1 to day 7, there are some patients that have levels of endotoxin activity above 0.6, which is the threshold that we usually use to treat patients together with other of course, our clinical factors. Also, thus, there is some evidence coming from experimental study that there is a synergistic effect of the spike protein of the virus and the endotoxin. So different animal studies showing that if you give a fixed dose of LPS with increasing dose of a spike protein, or on the other side, fixed dose of a spike protein and increasing dose of LPS, you can see here the synergistic effects, and also in this rat model of localized inflammation, again, the combination of LPS and spike protein produce synergistic effects at a local level. Together with Sylvia and other investigators, we described 12 patients with COVID-19 septic shock that were supported with PMX hemoperfusion. In the graph, you can see the nice relationship between the SOFA score and endotoxin activity. And in this graph, you can see the sequential measurements of different scores and biomarkers and vital signs during the following hours after the treatment, with a decrease in SOFA score, lactate levels, mean arterial pressure, and vasopressor index, showing this progression of these 12 patients with COVID and endotoxic shock supported with PMX hemoperfusion. So my conclusions is that COVID-19 critically ill patients have high viral load, high inflammation, and they have limited treatment options, hyperinflammatory state with activation of inflammation and coagulation. Bacterial co-infection is uncommon, but gram-negative superinfection is common. Then endotoxemia may worsen the inflammatory response and the risk for multi-organ failure, and it's a possible target for blood purification. With that, thank you for your attention.
Thank you very much, Ricard. So we're going to ask the third speaker to come on stage. This will be Giuseppe Castellano, who is the director of the Policlinico Milano. He's a professor of nephrology in Milano, and he's going to talk about complement system inhibition in septic-AKI requiring reimbursement therapy. What's the role of the polymethyl methacrylate membrane?
Mr. Chairman, ladies and gentlemen, thank you to inviting me to present our data. Presentation should start. Let's see. Okay. So you know that during acute kidney injury, we have a different possibility. When the damage is overwhelming the capacity of the kidney to respond to this inflammation, then we can have acute kidney disease that can go to renal replacement therapy and terminal kidney disease. Or we can have also fully recovery. Everything depends on the capacity of the kidney to respond to this maladaptive attack. The consequence of innate immunity activation might be detrimental, especially the activation of the complement system. We know that complement is part of the innate immune system, and the complement plays a major role in acute kidney injury, like, for example, in ischemia reperfusion injury or LPS-mediated acute kidney injury. And what is important to realize that complement is very strictly associated with the development of fibrosis. So if we are not able to block complement, we will have suddenly the development of fibrosis, also at renal level. And as you know, there are three different possibilities to activate complement: is the classical, the lectin, and the alternative pathway. What we have showed previously in different animal models and also in patients, especially in transplanted patients that develop acute kidney injury, is that you can have maladaptive response to acute kidney injury. Like, for example, one response is the endothelial to mesenchymal transition that can induce by LPS. So endothelial cells, as you can see here, on the left, they normally have inside the CD31 marker, and the alpha-SMA is green, is located outside. During LPS-induced AKI, you have a different composition of the tubular interstitium of the kidney, in which the green indicates the endothelial cells that are transforming in myofibroblast. And this will be really detrimental for renal vessels and contribute to the maladaptive response during acute kidney injury. Another important cells that can react badly to LPS-induced AKI are the pericytes, because pericytes can regulate the blood size and the perfusion within the kidney. And as you can see here, also pericytes add this transdifferentiation towards the myofibroblast, because when you have the fibrotic kidney, the major of the cells within fibrotic kidney are represented by this myofibroblast. And this myofibroblast comes from endothelial cells or pericytes that have differentiated. And what we have shown in our data, and also other lab have demonstrated, is that complement is much more potent, for example, of TGF-beta in inducing fibrosis in renal cells. So the message is that we have to try to block as soon as possible complement activation. We have to inhibit complement not only in this setting, but also in other setting of acute damage. And finally, we published this paper in Aging because we show that complement can induce a very particular response in tubular epithelial cells. That is the induction of senescence. So during acute kidney injury, you do not only have apoptosis or necrosis, but you can have senescence of tubular epithelial cells. What is a senescent cell? A senescent cell is a cell that has arrested the cell cycle, is stable, do not proliferate, but start to produce IL-6, TGF-beta, and this is really detrimental for all the tubular interstitium. So during acute kidney injury, we have transdifferentiation towards myofibroblasts, or we have induction of the senescent cells that have been called SASP, so senescence-associated secretory phenotype. And actually, we do not have drugs that can kill these senescent cells because we should require the senolytic drugs, as really they are really impossible to be killed. So in synthesis, if we block complement during acute kidney injury, we can block renal aging because the kidney can go in accelerated aging in days, as we show, but also was confirmed by other groups. So as our previous speaker said, during sepsis, we have an immune response hyperactivated that is driven by LPS, by DAMPs and PAMPs. And between these factors that have activated, there is complement. And complement, and as you can see here in this picture already showed, is activated with the coagulation cascade, especially at the site of endothelial cells, leading to the damage of microcirculation. And this damage is then be shown in different organs and in the kidney. This activation of complement is driven by LPS. And LPS, it has been shown that can induce activation of the alternative pathway. LPS is a very potent activator of the alternative pathway. But in vivo, it has been not really investigated so far. So we plan a study in which we investigated in vivo also this activation, especially because now we have the possibility to apply this treatment, this new treatment, with adsorption capacity. And in complement, there are different factors that can be adsorbed and removed, like C3A, C5A, or C5b29. So it's really important for us that we have a system that can not only block but adsorb complement activation. And a member like polymethyl methacrylate, we have tested in an in vivo model. Why we choose PMMA? Because as you can see here, PMMA compared to polysulfone can have a much more potent adsorption of different kind of circulating protein. So it's really a membrane with capacity of adsorb which kind of protein we would like to absorb. The anaphylatoxin, first of all, C3A and C5A, that have a detrimental role, as I told you, on endothelial cells, on pericytes, and on renal tubular epithelial cells. So in this study, this new study, we want to investigate the new pathogenic mechanism linking LPS induction of AKI with activation of the immune system. We investigate in vivo, in a swine model of LPS-induced AKI, the efficacy of this new polymethyl methacrylate membrane with continuous hemofiltration. And we compare towards polysulfone-based treatment. What we analyze, and this is an important point, was the activation of the immune system at circulating level, because you can have complement activation into the circulation, but also it is important to analyze tissue activation of complement. And this is really important for us to clarify if a therapeutic intervention is good or not. So we start with the LPS infusion, and then after 3 hours, we start different type of CVVH treatment with polymethyl methacrylate or polysulfone. And then, at the end of treatment, supportive therapy. After 24 hours, we sacrifice the animal. So, is there a difference between different membrane? Our answer is yes, because if you see the creatinine level, if you see also the urine output and the mean arterial blood pressure, if you are able to absorb protein like complements, I told you, you will have a better urinary output and a better mean arterial pressure. So we had clinical data, very important in pigs, and these pigs, I have to tell you, they weigh between 50 and 60 kilograms, so they are really in a size, in important size. And also we found in the publication, you will see also a reduced mortality in pigs, in the PMMA treated pigs. Then we wanted to investigate in renal parenchyma what was happening. And as you can see here, in PMMA-based CVVH, you can see already a less recruitment of leukocyte at renal level, indicating less inflammation. Then we analyze, this is an important analysis that we conduct at tissue, the level of fibrosis, because in our data that we confirm also in transplanted patients with the AKI, in which we perform renal biopsy, we can see that this process of acute fibrosis is occurring already in 24 hours. So if you do not block this system, you have this green staining indicated collagen. So where you have collagen in that area, there will be no cell anymore. So it's a parenchyma, renal parenchyma that will be impossible to be recuperated, that be integrated. Again, when we treat with the PMMH, we have very, very less level of kidney fibrosis in acute setting already in 24 hours, and this was better than the treatment with polysulfone. Then we start to analyze, after clinical data, after histology, the activation of the immune system at the renal level. As you can see here, we expect also this, but it's nice to be confirmed also in animal model, is that LPS induce activation of complement in terms of C5b29 deposition, and the system, because this is also important, we should analyze always the trigger of complement. And in our hand, the trigger of complement system is pentraxin 3. Pentraxin 3 is a protein of the member of the CRP protein, and is capable to activate the classical pathway of complement. So this is really important. We investigate this, and we found that pentraxin 3 in these pigs is deposited at renal level and by this pentraxin 3 deposition, you have C1q and complement pathway activation, with the classical pathway. The capacity of polysulfone to remove this complement activation was limited, but when we analyze the tissue of the PMMA-based treatment, we found really spectacular results because the complement was completely abrogated. Then the question is, at tissue level, we have a good inhibition of complement. Let's go to the plasma. What is happening at systemic level? And then we apply the VSLab kit. Is a very nice kit working on plasma. And with this system, you can see the activation of the classical, the alternative, and the lectin pathway. And as you can see here, the classical pathway is activated already after 3 hours. This is the systemic pathway. And at 24 hours, the treatment with the PMMA leads to a significant inhibition of the classical pathway at circulating level. The same, it has been shown for the alternative pathway. We expect the alternative pathway because, as I told you, LPS induce alternative pathway activation. And we have also a 24 hours inhibition by polymethyl methacrylate treatment, no effect on the lectin pathway. So in vivo, LPS induce not only the alternative pathway, but also the classical pathway of complement. And in tissue level, we confirm this data because we had the deposition of P3X3 that is a modulator of the classical pathway. So the answer is yes. During LPS-induced AKI, we have an important activation of complement of the classical and the alternative pathway. Another important issue is the capacity of PMMA to decrease LPS binding protein. That this is really critical in signaling of LPS into the cells. And then we apply the omics technique to see how the circulating leukocytes respond to this new treatment in pigs. So we apply in pigs the microarray Agilent chip. As you can see here, all these dots are gene regulated, up and down regulated, and then we will do the final analysis in the next slides. You can see here there is a clear response of the pig to LPS after 24 hours. But what we can have, and this is interesting, with the PMMA, you can really change the way the leukocytes respond to LPS, because on the right, you have in red the circulating leukocytes in LPS-induced AKI. If you treat with polymethyl methacrylate these pigs, then the response of circulating leukocytes is completely different. And when we go inside to analyze which of these genes, because you have hundreds of genes, so you have to show the better modulated of these genes, the more significant modulated, we found, again, signs of activation of the cells. So like granzyme B, much more activated by LPS, modulated in a significant way by PMMA, and we found that this was really interesting, the complement factor B. So another important issue that we discovered is that during LPS-induced AKI, circulating leukocytes produce complement factor B that is a really important activator of the alternative pathway. Again, with PMMA, we have downregulation of complement factor B production. Then we analyze also other data, and the results are in terms of an anti-inflammatory response. So what happened for complement in COVID-19? Because we heard about COVID-19, the superinfection. And this was really interesting for people that study complement, because we found, and also others, that complement is hyperactivated in this patient. This patient, they have an increased susceptibility, incidence of acute kidney injury. So what is possible to speculate is that in COVID-19 patient with superinfection and acute kidney injury, the complement had a major role in inducing tissue damage. And different publications have put a role for complement in COVID-19 patient as a target to try to counteract acute kidney injury. So, in conclusion, in our animal model, we tested a new membrane for CVVH capable to modulate innate immune system in response to LPS-induced acute kidney injury. What we found was a better urinary output, less mortality, an increased capacity to control LPS-induced inflammation, and since we are nephrologists, we are really interested to renal effects, to AKI, and we found at histological level really reduced renal damage, reduced complement deposition in terms of PTX3, C5b29, but especially reduced fibrosis, because remember, when you have fibrosis, it is impossible to recover at renal level. Finally, the omics analysis indicates that with this approach, you can really efficiently remove this overactivation of the immune system, and we analyze the complete transcriptome of the circulating leukocyte. This, for us, might be really interesting for the future therapies, because it is not important only to remove LPS, but think about all that is being induced by LPS. And as I showed you, I hope I convinced you that LPS is a very potent trigger of complement activation that we are not capable to remove with classical polysulfone-based treatment. I would like to thank all my collaborators in University of Milan, Bari, and Foggia, and you for your attention.
So we are going to have the questions at the end and the discussion. So my pleasure to introduce Silvia De Rosa from Vicenza, Italy. She's going to discuss about polymyxin Hemoperfusion and sets in endotoxic shock, timing and dose. Thank you, Silvia.
Thank you, Ricard, for your kind invitation. So, as we saw before, we have as a basis of our pathophysiology, we have a host and pathogen interaction. And from one side, we have a pro-inflammatory response, and from the other side, anti-inflammatory response that increase the immunosuppression, increase host susceptibility to secondary infection. And what we saw is that we have a multi-organ failure, and also what we saw before was the role of the LPS and the interaction of LPS for also this important organ failure. And the human body is has high sensitivity for endotoxin, and this is really important also when we consider experimental study, because the murine as model has high resistance on concerning endotoxin. So high endotoxin level can can evoke acute kidney injury, acute respiratory failure, can affect the heart, and can affect the liver, the endothelium. And what we saw with this picture is that when we give antibiotic to our patient with gram-negative infection, we can have such an explosion, so the LPS increase in our blood. So in all culture, as we can see in this experimental study, what they saw was an increase in total or free endotoxic concentration after antibiotic administration. And so depends on which kind of antibiotic we are using, we can have high, intermediate, or low endotoxin release. So we have to be careful when we give antibiotic, because probably we need agent therapy to support this. What we know that during episode of severe endotoxemia, concentration of both lipopolysaccharide and its lipid course fraction liberated from gram-negative bacteria and become elevated within the systemic circulation. Polymyxin B has a really high binding avidity for the lipid course fraction of lipopolysaccharide, so can be useful for us. And beyond peak concentration hypothesis, we can use blood purification therapy, and in this case, hemoperfusion to remove endotoxin and to block, stop this kind of exaggerating inflammatory response. So could lowering the level of LPS in the blood treat septic shock more effectively than antibiotics alone? Probably yes, with the hemoperfusion. Or could lowering LPS level and removal previously released cytokines in the blood treat septic shock more effectively than antibiotics alone? Probably yes. We can use probably a sequential therapy with renal replacement therapy if we have a kidney failure and we can operate a multi-organ support. So what we have is a hemoperfusion, and basically is adsorption. So we have a cartridge. Inside this cartridge, we have a resin gel, is adsorbing substances that can allow us to remove, in this case, endotoxin. And when we have to assess the cartridge, so the adsorption of this cartridge, we have to assess the device adsorption capability and selectivity. So we have endotoxin burden, which is the quantity of circulating LPS in a patient that is affected by endotoxic shock, in this case. And we have the other side, the device adsorption capability is a specific property of a single device, and it can be defined as the amount of endotoxin that a single device is able to remove from the whole blood. So if we consider the endotoxin dose response curve, EA value of 0.9 corresponds to 4 nanogram per milliliter. It means that if we have a patient with endotoxin activity of 0.9 and the blood volume is 5 liters, the endotoxin burden is around 20 microgram. But we have to consider the interstitial space is 13,000 milliliter, and in this case, 0.9 endotoxin activity is equal 52 microgram, around 52 microgram. And over 0.9, we have what we correspond with high concentration endotoxin. It is such as endotoxin burden. So PMXB is a polycationic methylphilic cyclic decapeptide antimicrobial developed from Bacillus polymyxia. And if I administer polymyxin B in the blood of a patient, I could evoke a really side effect characterized by neurotoxicity or nephrotoxicity. So we cannot administer intravenously, but we can just covalently bind it to polypropylene and polystyrene fibers, and we can constitute a roll and put inside the cartridge, and using this kind of device that we name polymyxin B as a adjunct therapy to remove endotoxin. So this cartridge is inside the circuit. The blood flow is from 80 to 120 milliliter per minute. We can perform hemoperfusion of 2 hours, and we can apply for 2 consecutive days, so after 24 hours. And the anticoagulant that we can use is heparin, and we can use a continuous infusion of heparin, but studies are ongoing concerning the regional anticoagulation with the calcium citrate. So we can perform also, as we saw before, in a kind of immunomodulation, because it's not just removing endotoxin, but we can increase the HLA-DR expression, but also we can increase the percentage of Treg. So we have in literature a lot of study concerning this device. UFAS randomized control trial was performed in my center as a first Italian center, but involved 10 tertiary Italian ICU, where enrolled 64 patients. The absolute risk of death was at 20 days improved significantly from 53% in the conventional therapy group to 32% in the polymyx HP treated group. But endotoxin activity assay was not measured. And the treatment was started when there was an evidence of abdominal shock. This is another trial, the Abdomnix randomized control trial. This is a French, they enrolled 240 patients. They analyzed 20-day mortality in patients with septic shock due to peritonitis. And the 20 days mortality was 28% for PMX group versus control group, but was not significant. They had severe technical problems. And so the treatment was not for every time 2 hours because they have an issue concerning coagulation and decreased circuit life. So probably we have to read also limits of study every time. And the Euphrates randomized control trial was United States and Canada study because they involved 50 ICU and 1,450 patients were considered, and they consider patients with septic shock, and they measure endotoxin activity, and they enroll patients with the endotoxin activity, say, over 0.6. They found no difference at 20 days all-cause mortality, but they found that in some patients with septic shock, the burden of endotoxin activity was extreme. They enrolled patients with endotoxin activity, say, over 0.9. So probably were really severe patients. So they did an amendment to the protocol after the interim analysis that suggested lack of effect in the patient with mods or mods of 9 or less, and those patients were excluded. So they did a post-hoc analysis, and they reevaluated the use of polymyxin B in patients with septic shock, and they considered range between 0.6 to 0.89. And what they found was the mortality at 28 days was less, 26.14 compared to 36.79 of the sham group. So probably we have not still proved that it decreased 28 days mortality, but we have several studies. We have a significant mortality reduction also versus control. We are still working, and this was the first evaluation that the Surviving Sepsis campaign did before. They include all study from the beginning, but and it was a favor of polymyxin BHP, but at the end they considered just the less than this study, and considering that was not anymore favor, and the conclusion were a suggestion against, but was a weak recommendation. Concerning the timing, we have just this study that they analyzed early strategy hemoperfusion initiated within 90 hours and was significant in patients with intra-abdominal infection. Within 9 hours from after catecholamine treatment was the timing that they use. And they also, there was another study, in this study was considered SOFA score categories, and they found SOFA score categories of 7 to 9 and 10 to 12 categories where survival was significantly higher. So this is what we do in our clinical practice in our center. We have a flow chart for the treatment. So we consider our patient with septic shock, and we consider time also. We have a group, and we work together to find a really good patient that could achieve this treatment, because we don't want to waste time also. So we measure endotoxin activity assay. There should be over up of 0.6, or if it is less and we have positive blood culture, we confirm septic endotoxin shock, and we start with polymyxin B hemoperfusion. If our patient has renal failure, we consider sequential therapy using continuous renal replacement therapy. So this is what we did also with COVID-19 patient. We found patient with septic shock. we had an activation of a kidney replacement team group, and we assess our patient, we perform endotoxic activity assay, and when we confirm, we start, but we decide all together. So we perform first our bundle, we activated the team, we perform endotoxic activity assay, and within 6 hours, if we can, before 12, we start the treatment. We start the treatment, and we consider also if to consider the renal replacement therapy if our patient has renal failure. And this is when we say sequential extracorporeal therapy in septic shock. And this is a adjunct therapy. This is a bridge therapy that we use close to source control antibiotic therapy. So if we want to use correctly extracorporeal blood purification therapy, we have to apply this strategy. We have to do training. We have to have a good communication. We have to draft a local algorithm or flow chart. We have to avoid redundant prescription. And we have to create this multidisciplinary team because this is the secret to have a result for our patient. This is how it works in our center. We have a trained nurses and biologists of the team labs. The kidney replacement team is activated when there is a clinical diagnosis of septic shock in the emergency department. And the intensivist and the nephrologist expert in extracorporeal blood purification on the basis of the patient's clinical sign or health biological biomarkers can prescribe Polymyxin B Hemoperfusion treatment if specific indication exists. So I strongly believe that if we remove endotoxin, and this is the trigger, and we perform immunomodulation using a sequential therapy when we need, we can also remove a persistent cytokine production, and we can perform immunomodulation if we can support each organ. This is a EUFAS2 registry, and I strongly believe that registry could be the future for our clinical practice, to check our clinical practice, but also to have a really good data to evaluate it. And this is what we did in our center. We treated 61 patients, and this is a registry, so was our clinical practice. And those patients were not just abdominal, were patients also with respiratory failure. These were catecholamines reduction, and also we have an improvement of vasoactive inotropy score considering all entire cohort, and ectotoxic activity assay, and procalcitonin, and blood lactates also. But from 2019, we use a flow chart, and we assessed 34 patients. We performed first our bundle. We were just measure the endotoxic activity assay, and we apply what I told before concerning the flow chart. Before was just you have endotoxic activity assay 0.6, and they start the treatment. And what we saw was a decreasing of vasoactive inotropy score more than pre-flow chart. But what was nice was to find ICU mortality less, 29%. Hospital mortality was less, 38%. Also, we perform, we assess renal function, and we saw that considering urinary output criteria and the serum creatinine criteria, we have 82% of patients with acute kidney injury, and we start continuous renal replacement therapy in 75.4% of these patients. We perform in a lot of patients high volume, high hemofiltration. When we consider the balance of covariates, we did a propensity score, we found hospital mortality significant in favor to flow chart, and also 90 days mortalities. So in a comprehensive approach to the endotoxic shock treatment, the evaluation of kidney function, vasopressor requirement, endotoxemia, together with source control antibiotic therapy based on the time from sepsis diagnosis may have a role to personalize the treatment for each specific patient. The monitoring should be dynamic. The prescriptions should be dynamic because we want to achieve precision medicine. Not only a specific treatment could be provided for every single patient, but even a more specific treatment shall be provided for every moment that patient has a particular need to his, her ICU stay. So in my opinion, Polymyxin B Hemoperfusion is a safe blood purification therapy to be considered for management of a responsive endotoxic shock, resulting with the clinical benefit for our patient if we do in the right time with a right team, right patient. Are you agree? Thank you.
So now we invite all the speakers to the stage for having a discussion. So if anyone have any question, please go to the microphones, introduce yourself, and make the question.
For Silvia. Here.
Okay, sorry.
In Polymyxin Hemoperfusion,
Yeah.
you say that we have to use only heparin.
Yeah, for now you
anticoagulation.
can use heparin, but Professor Ferrer is studying about anticoagulation with citrate.
We have post-operative patient with peritonitis coming from the operating room, and we are maybe scared of use heparin, bolus of heparin and infusion in the immediate post-operative period. So I want to ask you if we could do hemoperfusion without any anticoagulation for 2 hours.
Yeah, it's for circuit life.
Even
Yeah.
for 2 hours, we have to do.
Because the blood flow is not so high,
Okay.
so you can have a
Clotting of the.
right.
Okay, thank you.
Thank you.
Any other question? Yes, please go to the mic. Thank you.
In last year, on Nature comes out a paper about the possibility that cytosorb link antibiotics, for example, during CRT treatment. Is there any evidence that even Polymyxin can have a scavenging effect on antibiotics?
So we have not a study. We have one study that was around 60% the possibility to remove antibiotics, but for each cartridge, we have to study still for antibiotic removals.
Of course, there are some antibiotics that can be absorbed to the cartridge, so the recommendation is, as the therapy lasts 2 hours, to use the antibiotic after the therapy. So I think that will be the best approach. So if there are no more questions from the audience, I have some of them for the speakers. So I think it's great news that we are talking about endotoxic shock. I mean that we are not talking broadly about sepsis or septic shock, that we are focusing on a specific phenotype, which I think is the current approach now. I mean that we know that with improvements in the process of care, antibiotics, source control, etc., we have a selected group of patients that are not responding to these therapies, and probably endotoxic shock is a subgroup of those patients that merits additional study and can be treated with the options we have right now. But can we identify better this phenotype of patients? Maybe Massimo, you can answer to that. Which is the phenotype of patients that we want to include in trials or what we want to select for personalized therapy in the ICUs?
Oh, great, Rico. Difficult question, of course, because the idea to measure endotoxin activity, that is quite simple. If you have the device, seems to be a very good idea. But after the trial published on tailored approach in patients with high endotoxin level, the question is, I think, more interesting, because probably not only the endotoxin level may identify the patient that could have benefit from blood purification with polymyxin B. And if you ask me, putting together my experience and literature overview of the polymyxin B, my first patient for blood purification in general, but in this case, I agree with you that the interesting part of polymyxin B absorption compared with other blood purification, that you know what the filter and the cartridge do exactly, and know what with other system you are in some way in a sort of black box for the activity. Anyway, coming back to the patient, I think that first of all, I think that we have to deserve this kind of in my practice, coming from of course data and literature. I use the system in patients very complex and complicated, because the meta-analysis show that blood purification with polymyxin B is more effective in patients with high SOFA score on shock the patient. So first of all. Second point, after 10 years, I think that I remain that probably patients with peritonitis and patients with high risk for gram-negative should be the first of my favorite patient phenotype patient in favor of use of polymyxin B. But I know that this is just probably a limited vision of the effects of endotoxin in the blood level. So anyway, coming back, patient with the peritonitis or gram-negative infection, quite frequent in the ICU, especially in Italy. And second, very sick patient, and with expression of hyperinflammatory state.
Thank you.
Do you see any other biomarkers that we could use to enrich the patient selection? I mean, besides endotoxin levels? Who wants to
Complement?
Yeah, for example, in COVID-19 patients, there was a recent paper in Nature and Professor Mantovani showing that the patient with high levels of complement, they went worse. So I think that the complement measurement into the circulation might be a good biomarker of patient with the overactivation of the immune system in response to infection.
Because I'm sure everyone here would agree that the problem that we have with all the blood purification techniques, polymyxin B, hemoperfusion, but also PMMA and some others, is that we get very interesting data from mechanistic studies like you presented today. But then after we get some conflicting results when it comes to clinical outcomes. And because of that, not all of us in the medical field are convinced, and so I think the problem is in some studies the patient selection was not good enough, and then we include in these trials so many patients, and then we get negative trials. So I think for the future it's very important to select very precisely the patients we're going to enroll in the future clinical studies. So that's why I'm asking if we can find any other biomarkers that we could use for patient selection in the future trials.
If you think about thrombotic microangiopathy, in which we use eculizumab, then we have a precision medicine approach. Then you have the mutation, and the inhibition of complement works perfectly. So you are right. You have to find the right patient which you can use this approach.
Thomas, just a different perspective. I think that the problem is to change our outcomes. I'm not sure that in septic shock patient with so many complexities, the 30-day mortality is an outcome. So I prefer to change the outcome than to change the inclusion criteria. But this is a large discussion,
Yeah.
So no, that's a very interesting point, because so when clinicians select patients for therapy and introduce the patient in a clinical trial, they have inclusion-exclusion criteria, have to stick on that. But when you introduce patients in phase 2 trial, you just use your clinical criteria to select patients for therapy.
Yeah.
Are so different the patients that are selected from clinicians that the patient selected for trials? And are the outcomes so different, which is the mortality in phase 2 compared to the mortality in phase or EUPHRATES is so different?
Yes. I strongly believe that the registry can show you, the center experience. Probably you can use registry to design new trials selecting center, because not everyone has the same way to assess patients. This is what I think.
So if we have to enrich the trials, we have to learn a lot about those important observational studies that where, as you mentioned, multidisciplinary teams select patients based in their knowledge and experience and the data they have for patients, for including the patients in the registries. And sometimes the patient selection is better in these registries than the patient selected for the trials that have many other considerations. Yeah. So a question for Professor Castellano, which is, I am not a nephrologist, and I want to understand a little bit more about these biocompatible membranes, PMMA. Those membranes are designed for any critical ill patients, or only for septic patients or inflammatory patients? So AKI in the ICU, we have to think in these biocompatible membranes, or just for a selected group of patients with sepsis?
We start in this situation of LPS-induced AKI, but anyway, we have experience in chronic hemodialysis, and when you perform chronic hemodialysis, complement is activated. And when we test also this membrane, we have a significant reduction of inflammation. So I think that you can use also in several settings, because the capacity to absorb this uremic toxin that are not the classical uremic toxic, but that are they recognize specific receptor on C3A, C5a receptor on endothelial cells. I think that gives a better outcome at cardiovascular level. Again, because we have tested also in chronic hemodialysis setting, so the contact with the membrane activates the immune system.
Okay.
Any other questions? Because we still have a couple of minutes. I have a question for Ricard. You showed interesting data comparing the rate of infections in COVID-19 patients as compared to influenza patients, and the rate was double. How do you explain this difference?
Well, I think there are many factors that can explain. One hypothesis could be that we have to recognize that some patients have not been treated the same during a significant wave, and with the staff overloaded and some additional staff without enough experience to be in the ICU. So at least in Spain, we have a bundle for BAP prevention that really failed to be applied during the different waves of the pandemic. So this can be part of the explanation. And to answer this hypothesis, maybe we have to wait when we have more, let's say, stable cases, and we can compare in a stable situation COVID versus non-COVID patients. Of course, the treatment we are using for treating COVID, as I mentioned before, steroids and tocilizumab can have an impact on the immunity of these patients in a condition that COVID by itself produces lymphopenia and other dysregulation in the immunity, and also severe damage to the epithelial cells. So this can be part of the COVID itself plus the treatment we are using. But also it's quite interesting to see that COVID increase blood thrombosis, and I don't know if it's your experience, but the amount of patients with necrotizing pneumonia has been impressive during the pandemic. So we have a lot of patients, that like the case I have shown you before, that the pneumonia evolution to a necrotizing form. And this in part is because probably blood flow in the lung is decreased, and because of the effects of the virus. So I think it's a combination of factors, and some of them, maybe during the next month we can know a little bit more about that.
Thank you, Ricard. So I think it's time to conclude. Ricard, would like to say the final words and to thank our sponsor?
Yes, of course. Thank you for those that are still here with us in this session. Thank you to Estor for supporting this session. I think we have a very interesting discussion, a different point of views about endotoxic shock, which I think is a specific phenotype we have to pay attention and we have to focus in the future. And there are other phenotypes in sepsis that also need specific attention and will be discussed in other forums. But for this one, I think we have a challenge in front of us. I think my generation at least did a big effort in reducing mortality in sepsis, improving the process of care. For the next generation, Sylvia and the others, the challenge is to improve, when we have a stable process of care, to improve those patients that antibiotics, source control, resuscitation, etc. is not enough, and this is an example of that. Thank you for being here. Thank you, Estor. Thank you, everybody.